It's perfect. Can I go ahead and introduce you?
Please go ahead. Thank you so much.
Excellent. Good morning, everyone. Thanks for joining us. I'm happy to introduce Dr. Pragya Verma Bhatnagar. She is giving us a talk this morning on HPV vaccine. Dr. Verma Bhatnagar is a pediatric and preventive medicine specialist who trained at the University of Texas, Morehouse, and Children's Healthcare of Atlanta with in-depth experience in clinical and preventive solutions for health problems in children. She completed her residency training in pediatrics at Morehouse School of Medicine with clinical training at Children's Healthcare of Atlanta, the Centers for Disease Control and Prevention, and private practices in and around the greater Atlanta region, along with experience at the only state-level school-based health center. Dr. Verma Bhatnagar has had the opportunity to work in both hospital-based and community settings, and her areas of interest include pediatric allergy and asthma, sickle cell disease, and pediatric obesity. She's very excited to be part of the expansion of pediatric services in the fast-growing coming area. She strives to espouse a personal approach with teamwork to help the needs of the children and the families that call Georgia Highlands their medical home. She lives in Cumming with her husband and young daughter, and they love the mountains and exploring parks and trails. In her spare time, she loves to volunteer for FAIR, which is the Food Allergy Research and Education, and conduct food allergy awareness workshops for school students and teachers. Please help me welcome Dr. Verma Bhatnagar.
Good morning. Thank you so much for inviting me. This is my first time presenting at the Piedmont Columbus Regional Pediatric Grand Rounds. Thank you for the opportunity. As I was introduced very glowingly, thank you very much for that. I am a pediatric and preventive medicine specialist, and I've been practicing at Highlands Pediatrics since 2017. We are part of Georgia Highlands Medical Services, which is a large AFQHC serving the North Georgia area. And we have witnessed rapid growth in the demand for pediatric services in our area, notwithstanding the COVID pandemic. Today, I am going to be speaking about HPV vaccines. This, I believe, is an area that me and my staff encounter every day in our clinical lives, whether it's talking about dispensing the information about the vaccine, stocking, administering it, doing the follow-ups with the families. So in other words, we are part of that HPV ecosystem almost daily with our clinical lives. So without much further ado, let's just dive right in. This is just my presenter disclosure information. I don't have any relationships to disclose. HPV vaccine, I believe, within even the vaccine ecosystem, has a lot of myths and beliefs associated with it. And today in my presentation, what I would hope and wish to do is to persuade that HPV vaccine is worth the advocacy. HPV vaccine is worth giving before exposure. Your recommendation as a healthcare provider matters, and the pediatrician's role is vital in this sort of food chain of vaccines. And again, if there is nothing else that you remember from this presentation, but these simple points, your take-home message, I hope, is going to be that the HPV infection is way more common than any of us think. Most of our patients will get exposed to this during their lifetime. It works. Hello? Oh, it works very well at the recommended age of 11 to 12 years of age. Early vaccination is way more effective than later vaccination. Parents, in fact, want this vaccine more than you think. It has a proven safety record, and evidence-based recommendations on how to vaccinate or how to bring about the conversation do exist. So let's meet the virus that we are, we'll be spending the next hour talking about. The HPV virus is one that infects human skin and mucosal surfaces. So in a way, it infects the largest organ of the body, Most females and males will be infected with at least one type of the mucosal HPV virus at some point. It has various subtypes, as we'll find out later in the presentation. It can be transmitted as easily as by touching, and the virus has been classified as a carcinogen. Again, this is important in framing how we discuss about this particular virus and the vaccine. So why do we worry about this? What impact or what disease load does the HPV vaccine virus cause? Depending on the source that you are looking at, in the United States itself, anywhere from 8 to 14 million people are newly infected every year. Out of that, around 45,000 new cancer cases in the US are attributable to the HPV virus versus almost 570,000, I would say around 10 times that number worldwide. This is data from 2018. And out of the new cancer cases, around 8,000 attributable deaths in the United States versus 300,000 attributable deaths in around worldwide in 2018. What will catch your attention in the figures below is that the age of diagnosis, the median age of diagnosis for this virus is later in life. So if you look at for females, if you check out, let's say, cervical cancer, late 40s, early 50s, the other kind of cancers that do infect the female population, we have vaginal, oropharyngeal, vulvar, anal. All of those are in the 60s as the age of diagnosis. For the males, the topmost is the oropharyngeal cancer. And then we also get penile cancer or anal cancer attributable to the particular virus, to HPV virus. And again, you will see that the median age of diagnosis is in early to late 60s. As pediatricians, therefore, it's because you're not going to see this. We are not going to see cancers in our population, but at the same time, we are vaccinating for a disease that is going to happen in the future. And knowing this information, I guess, again, frames the conversation or helps to frame the conversation with the parents. This is across the United States, the distribution by state, again, of all HPV-associated cancers. You will see that the concentration, so to speak, is in the southeast to the southern areas of the country. So knowing that, it is a ubiquitous virus in that sense, it is a virus that can easily infect and in fact infects millions of people and has various kinds of cancers associated with it. It brings us to our next question as to why do we vaccinate? Before we dive into why do we vaccinate, I think for me, this figure from the CDC speaks a lot. A lot of times when I'm talking to my parents in clinic, I will pull this up on my phone and, I show it to them and we, discuss off of it. When we think of HPV, I think we always default to cervical cancer. We need to reframe that particular point as well. Screening will not protect our patients from most of the HPV cancers. Cervical cancer, which we default to, is the only type of HPV cancer for which there is a recommended screening test, the Pap smears. But even with the screening, HPV causes 10,000 of almost 11,000 cases of cervical cancer each year in the U.S. With the precancerous lesions, a lot of my parents will say, well, when my child grows up and will start to do their regular OB-GYN visits, they will be screened for stuff like this. And a lot of times if they are picked up at an early stage, the treatment is available. So again, why should I vaccinate at 11? Well, this again speaks to that point. High-grade cervical lesions over 300,000 of those, which, while they're routinely screened for, they require invasive treatment, invasive testing, which also comes with its own drawbacks. And then there is this litany or host of other cancers, penile, vulvar, anal, oropharyngeal, which do not have any kind of screening tests available, and they are detected much later. By that time, health problems have already arisen. You will, hear more about oropharyngeal cancer later in the presentation, which also I feel needs to be spoken about more in reframing the way we speak about the HPV vaccines. So the reason we vaccinate, we want to prevent infections before they even happen. We want to definitely prevent the associated cancers, knowing very well that many of these cancers do not have any current screening recommendations. The related health conditions, I think, we have spoken about that in the previous slides as well, but I just put this slide in to show what the disease, potentially looks like. Again, as pediatricians, we probably will not be seeing this, but the family practitioners in my audience or adult caregivers in my audience will be, quite familiar with presentations like this. The treatment of the cervical precancerous lesions can lead to increased risk of preterm delivery. There is the risk of premature rupture of membranes, low birth weight, and the long-term developmental costs that one can incur, because of having a premature baby. In men, oropharyngeal cancers are more common. There is no screening test. And then, of course, you can have the others, the anal, penile, as well as genital cancer. This slide, the reason I included this, I found this personally also very interesting to note. Again, the population that I practice with, I normally don't encounter this in my clinical life on a regular basis. But studies have shown, and there are various in the literature, where the share of HPV causing oropharyngeal cancers has increased significantly over the past few decades. Basically, what this slide is trying to show us is that HPV positive oropharyngeal cancers versus HPV negative oropharyngeal cancers, those are like cigarette smoking related, alcohol related. The ratio of the red line basically is going up and the blue line is coming down. So we have done a good job, I think, by talking about, smoking, tobacco, alcohol, and the carcinogenic effects that substances like those can have on our body, but somehow the virus causing the similar cancers has not been spoken about as much. So again, almost everyone will get exposed. Many infections clear up on their own. So that's important to know as well when we are talking to parents, that your immune system will be able to clear many of these infections out. However, there are others that persist, and some reactivate decades after initial exposure. Again, the timelines are so long drawn that it is next to impossible to predict, who gets what, in other words. Sexual transmission routes is what normally, we associate HPV infections with. And definitely that is the most common route. It is sexual intercourse, genital to genital, anal genital, oral genital, or manual genital. Talking about the population, we do take care of a lot of adolescents here as well. Nearly 50% of high school students have already engaged in sexual or sexual intercourse. 1/3 of 9th graders, 2/3 of 12th graders have also engaged in sexual intercourse. And approximately 1/4 of high school seniors have had intercourse with 4 or more partners. Again, these are, numbers that may switch around a little bit over the years, but haven't had big changes. At the same time, we need to be aware that HPV can be transmitted without indulging in sexual intercourse. There have been studies done which examine the frequency of vaginal HPV and the association with non-coital sexual behavior, intimate behavior. Those, adolescent women have been followed. HPV has been detected in women even prior to first sexual encounter. The percentage ranges from 9 to 46%, again, depending on the study. 70% of those women, or these women in the studies, reported non-coital behaviors that may explain in part the transmission. So again, we have to, talk to our teenagers, talk to our adolescent patients and their families, because it's not always the traditional sexual transmission route that is the only way the virus can get transmitted. And that's why that brings us to why we vaccinate them right at the threshold, you can say, of middle school or, late elementary school. The rationale for vaccinating early is because you want to protect prior to exposure to the HPV virus and all its different subtypes. Again, data has shown from various studies that the longer we wait, they probably have already been exposed to at least one or more subtypes. In this particular study, 700 women aged 35 to 60. Okay, so again, this is not an age range that I see. 13% of incident infections were attributed to new sexual partners. Most of the infections occurred during either periods of abstinence or monogamy. In fact, I have an anecdote to share where the parent of one of my patients was diagnosed with early HPV associated cervical precancerous lesion, and she has been in a stable relationship. It's a stable family, and she was completely shocked. And she came up to me to, inquire about, can this happen to her? And then how can she protect her daughters? So a lot of times our conversations actually begin from that. And then we segue into advocating for giving early vaccination to not just the daughter, but also the son. She has 2 daughters and 1 son. So again, early vaccination can prevent that initial infection. So let's talk about, we talked about the virus, we talked about the impact, we talked about all the different associated cancers it can cause potentially, and the fact that most of them don't have any screening tools available right now. So, but we do have primary prevention, which is an HPV vaccine. The HPV vaccine is a recombinant L1 capsid protein, which forms virus-like particles, or as they say, VLPs. These VLPs are non-infectious, they're non-oncogenic, most importantly, and they are capable of producing higher levels of neutralizing antibodies in comparison to, let's say, a natural infection, which again, most of them will say, well, it's ubiquitous, you will end up getting natural infection. So why can't that natural infection help me combat the higher risk varieties that may end up causing cancer later in life? Well, again, you have a product that gives you a higher level of, and a sustained level of neutralizing antibodies, let's just say that, than natural infection will. The FDA has approved 3 products. Cervarix, which is the bivalent HPV vaccine. It covers HPV subtypes 16 and 18. This is, the most common subtype found to be associated with cervical cancer in females. This particular vaccine is only available for females. Gardasil, when it first came out, I remember when I think I was in residency, was a quadrivalent HPV vaccine, which also included coverage against HPV 6 and 11. And then subsequently, we have Gardasil 9, which is a 9-valent HPV vaccine. And it covers not just the genital warts and the 16 and 18, the high-risk types, which cause cervical cancer, but also the other subtypes, 31, 33, and it goes on. Both of these, Gardasil Quad as well as 9-valent, can be given to male and females both. The most recent ACIP recommendations recommend that they can be given to children as early as 9, even though they are routinely recommended at age 11 or 12. At my practice, we give it at age 11, or we start recommending at age 11. But we start talking about this vaccine from their 9-year checkup, and then try to reinforce it again at 10-year checkup, because at around 9, parents come in because they need their lipid screenings, and most of the times the first question they'll be asking is they don't have any vaccines, and we're like, no, it's a vaccine-free visit and the child is happy. But I always take that opportunity to sort of segue in and say, by the way, at 11, at your 11th birthday, when you will come for your checkups, there are these 3 vaccines that we recommend. And it's Tdap, HPV, Menactra, or whichever order you want to say it in. And then if you have any questions, this is a good opportunity to talk about it. So in other words, instead of springing it upon them at their 11th checkup, where they may not have enough time to think, or they may default to what they may have read on social media post or spoken to their families and friends, I feel it's a smart choice to give them information about this at an earlier checkup. The vaccination is recommended for all persons through age 26. Adults who are over age 26 can have shared clinical decision making regarding whether the HPV vaccine is recommended for their particular situation or not, and then it's not licensed for use in adults over 45. So basically the gray zone is, or the period is 27 to 45, where you can have a shared clinical decision making with your provider. Again, you don't need any pre-vaccination testing. You don't need a pap smear or test for HPV before you, give the vaccine. The cervical cancer screening guidelines that have also been updated, they need to be followed. There is no change on that. Again, with special populations or medical conditions, the vaccine is recommended. There is no change in the dosing or the frequency. If your patient is pregnant, HPV vaccine should be delayed until after pregnancy, but pregnancy testing is not needed before vaccination. And mothers who are breastfeeding or lactating can also receive the HPV vaccine. The updated recommendations did not change that. So what is the dosing schedule? The dosing schedule is based on age. Again, earlier you catch them and you vaccinate by their 14th birthday, they only need 2 doses. So, it's 0 and 6 months, or 6 to 12 months. After, or once they are 15 and older, they will need 3 doses, and that's divided as 0, 1, and 6 months of age. The blurb over here basically also gets into more details about what is the difference or the time gap between your second and third dose, or your first and third dose. So if you're interested, you can dive into that more into detail. We sometimes have to look at this for patients that are coming from outside the country because HPV vaccine is given in other countries in the world as well. Interchangeability, again, another important aspect. We see a lot of newly immigrated families from honestly all around the world, and they may have started their HPV vaccination process with a different product. So vaccination, providers, if you don't have a particular product, you need to, know or read this slide. In females, any HPV vaccine product may be used to continue or complete the series. In males, either the quad or the 9-valent may be used to continue or complete the series. I feel in my practice, we have been using the 9-valent HPV, but we've had some patients that may have started on the quad-valent, and then we just use the 9-valent to complete their vaccine. The other very important stakeholder in this conversation of vaccines are parents. Parents, the main question they will have is this safe? That's their first question always. Does the vaccine work? Allergic risk, and then will my child's behavior change? I think when the vaccine was first introduced, it was introduced as a vaccine that was given primarily to girls. And then the recommendation to include boys arrived in 2009, 2010. And I believe like by 2011, we had started to vaccinate both the genders. So somehow this was related or got tagged with gender behavior, and it got tagged into the whole gender ecosystem. The reality is the virus does not distinguish or differentiate. The virus honestly does not know whether you're a male or a female. It does not see your face or your picture. So a lot of times, my conversation with my parents will start by making it gender neutral. So their first question is, it's safe? HPV vaccine is safe. The benefits of the HPV vaccination far outweigh any potential risk. The safety studies that have been done on HPV find similar safety reviews to a Tdap or a Menactra. The vaccine works. Population impact against early and mid outcomes have been reported in multiple countries around the world, and it has been shown to have long lasting protection that sustains. So since the HPV vaccine was introduced, the next couple of slides will talk about the impact and whether it has worked or not. So in cervical cancer, as well as in anal cancer, there are certain subtypes that have been found to be high risk. What studies have found, and this is one particular one, but there are various in the literature, the prevalence of the high risk subtypes of the virus have trended towards decreasing prevalence, whereas the other subtypes, let's say that the vaccine is not covering, have been are trending towards increasing prevalence. So whether it's cervical cancer or anal, that's what we have found. In another study of around 1,600 patients who were younger than 27 presenting to the colposcopy clinics, vaccinated women had 53% lower odds of presenting with high-grade cytology, and 36% had lower odds of presenting with CINs, cervical intraepithelial neoplasia, grade 2, 3, or worse. And this is a study from Australia where the vaccination was introduced in this time frame after in and around 2007. The prevalence of genital warts was significant, and they have found a near disappearance of genital warts following introduction of the vaccine. They have been able to achieve almost 70% vaccination rate for females only. And again, as you can see in this, 93% reduction in girls younger than 21, 82% reduction in boys younger than 21. And again, genital warts is one of the conditions that is caused by this particular virus. And if you extrapolate the pyramid that we had seen, in slide 3, where we were talking about the tip of the pyramid, and then, the tip of the iceberg, so to speak, sorry, it was an iceberg, and then, the conditions that are hidden underneath, if we extrapolate to the vaccine efficacy based on the Australian data, they have found, again, 35% reduction in CIN, 92% reduction in warts, so a significant reduction in warts, 46% reduction in the high-grade CINs, which may require invasive procedure. This, I think, increases to 75% if early vaccination is given to the girls and the boys. And then cervical cancer is literally, very, very minimal. So, I mean, again, the impact is present. The impact of the vaccination is there. And then this is one of my favorite slides, because I also wasn't aware of this to the extent that while preparing for this presentation, I, encountered this. Impact on oral cancer. The rate of new diagnosis of HPV-related oropharyngeal squamous cell carcinoma, which has shown a dramatic rate of increase in the United States, with HPV now being observed in 70% of these tumors. It shows, or recent data shows, that HPV-related oropharyngeal cancers exceeds that of HPV-related cervical cancer in the US. So I was like, that's, I think we need to, or I needed to be aware of this, and definitely my staff needs to be aware of this, because we don't talk about this when we talk to our parents, when we are, talking about HPV vaccine. And giving even one dose of that, of the vaccine gets gets oral HPV infections 88% lower. Again, younger you are or earlier you do it before exposure, your impact is tremendous. And definitely public awareness remains low of this. So in summary, HPV infection is omnipresent. It causes cancers. We have primary prevention, or HPV vaccine, which is effective and safe if given at an early, if given during the early window, as well as, you give it or you complete the dose series younger than 14 or by their 14th birthday. Then the question always is, why is there still so much confusion or myths about this particular vaccine, and where is our messaging getting lost? This is the TeenVax page on the CDC's website, where you can plug in the vaccine that you're studying, and the data sort of pops up. If you see vaccination coverage among adolescents age 13 to 17 in the US under the NIS, which is the National Immunization Survey, the green worm and the blue worm sort of, go very close together, the Tdap booster, the Menactra. But the HPV worms, which, have you taken your first dose? Have you completed all the 3 doses? Definitely, when it comes to all 3 doses, you are at your lowest. At least the, worm which says you've had 1 dose is still up there, which, is heartening for me to see, even though it's not matching steps with the other vaccines that are given, which is Tdap and Menactra. Again, a lot of times in my conversation with our families, in our practice, the MAs go in to, while they're rooming the patient in, they go in and start talking about vaccines. So we honestly start talking about vaccines right from the time they, their visit starts, so to speak. In fact, sometimes even before that, when they are speaking to the schedulers on the phone. But while they are being roomed in, they will be provided with their VIS forms, the vaccine information sheets. And a lot of parents, other than asking, is it safe? Is it, will it change my child's behavior? They will also ask, what is needed for school? Because they are just wanting to get the bare minimum done just so that their child continues to be at school. Most of the times because they've either received a letter from school or they have received, some kind of communication where they realize the importance of getting the vaccine. HPV vaccine is not mandatory for school. Tdap and Menactra are. And I feel that sometimes as soon as they hear that, they will default, choose Tdap and Menactra, and then, not talk about HPV. What we have tried to do is, and on a busy day in clinic, it may not always be possible with every family or every patient, but we try to keep the door open and say, hey, why don't you have Dr. Verma, when she comes to talk to you about your child's visit, bring this up. Or I'm pretty sure she'll bring this up when she's talking to you guys during the visit. So in a way, we try to keep the door open so that when the visit starts, I'm like, okay, have you reviewed the VIS forms? Do you have any questions? What are the vaccines, you would like to receive today? And that's how, we start the conversation. This is the vaccination rates by state in the United States. Again, I feel that, because I live in Georgia, I've practiced in Georgia, I've been here for almost 10 plus years. If I feel that the rate of, of HPV cancer is high in the Southeast as well as in the southern states, and somewhere even the uptake of the vaccine is lower in the same geography, so to speak. This particular slide speaks to the impact of missed opportunities. So by age 13, basically. So what is the rate or percentage vaccinated in girls with 1 dose of HPV vaccine versus what could have been achievable, and it's almost like a 50%, gap. So there is definitely work that needs to be done. We all, I guess, agree, and we know that. And then what are the delays that lead to this missed opportunity? I feel that the delays are, if you do a 360 evaluation, so to speak, of this, whether it's the providers that are recommending this particular vaccine or the parents that have to sign off and consent, the delays exist on both spectrum. Again, this is a particular study, I believe it was in Pediatrics. And it looked at factors from both the provider as well as the parent perspective. And there were providers who said, I would honestly say it's rare. I spend not more than 20 seconds on it at 11. So few 11-year-olds are physically mature to be sexually active. And sometimes it's a sort of an awkward conversation. And again, I feel that reframing is important. This is a vaccine that is working against cancer. And we should not always start off thinking it has to do with sexual initiation or sexual activity. And with parents, sometimes parents do not understand that the vaccine is most effective when all doses are finished by age 14. I thought that it didn't really make any difference as long as they had those vaccines before, before they were 20 or in their 20s. These delays, which were originally intended to be temporary, potentially can become permanent. Again, the messaging this has to be given early. If you take it early, you only need 2 doses and you'll be done by your 14th birthday. You don't have to then worry about it later in your life. And the consequences of delaying it, which originally you may have thought were temporary, don't have the potential to become permanent. The other thing, which we encounter with adolescent visits, which a lot of pediatricians in the audience will also be familiar with, is that not a lot of them present for preventive care. We start to see that, slack off, so to speak. They will be there for their infant visits, toddler visits, preschool visits, elementary school visits, all of that. But then once, the children start to grow, these preventive visits start to drop. 30% of teenagers never present for preventive visits. 1 in 15 adolescent visits is for preventive care. So mostly they're doing episodic care, acute care, sick care. Preventive visits decline after age 13. And early adolescents had more preventive visits than later adolescents. So again, if you can do this early on and finish it, I think it's your best bet. Also, using both sick and well visits to vaccinate may be maybe your best bet too. I will like to say that because of the COVID pandemic and trying to do everything, we had to separate our sick visits and our well visits, and vaccines were not typically stocked in the sick areas or in our sick suites. So we were not able to do this strategy during the pandemic. And as I have alluded earlier in the presentation, framing matters. Effective framing matters. Like when you bundle it up, when you just say today your child, is due for 3 vaccines and then those are the vaccines. You can make your job harder by saying, you need Tdap and meningococcal. We should also talk about this, because then parents sense some kind of confusion, or they feel that, oh, there is something special about this vaccine. That's why you're, sort of, it's an afterthought, or you're mentioning it differently or separately. I feel that if it's framed properly, many parents will just say yes, because, and also if you've spoken about that at their 9th physical or their 10th physical or 10th year physical, then they will have that memory and be like, oh yeah, we talked about this. Okay, yeah, I think we are fine. Yeah, let's go ahead. So effective framing works 10 times better. Another study, which looked at reasons parents have not vaccinated. Again, this is the National Immunization Survey for Teens. For both boys and girls, they are not sexually active. They don't need this particular vaccine. That is common. A lot of times for boys, it was not even recommended by the provider, by the caregiver. safety concerns, they don't need it, or plain simple lack of knowledge, which was consistent for both genders. So I mean, you know, again, we can't work on every aspect of this, but we can definitely work on lack of knowledge. We can work about the recommendation part of it. We can definitely talk to them about the safety part of it. So there are, you know, there are areas that we can definitely work as well as update the knowledge of the parents. The next couple of slides I have, I feel this is more real world, or, you know, I think that we need to know how to answer these questions in real world. So let me play this.
Hey, what's up, Jose? I have an HPV question. Sure, what's up? Jake just had an annual checkup, and they recommended he get his HPV vaccine when he was first year. Why is it needed at such a young age?
Like with any vaccine, we want to give HPV vaccine earlier rather than later to protect your son before he's ever exposed to the virus.
Okay. Did you vaccinate your sons?
Definitely, I gave HPV vaccine to both my sons when they turned 11. It's important for preventing cancer that are caused by HPV.
Got it. Makes sense. Thanks, Jose.
The nurses and MAs and even the receptionists all need to understand that we're doing this because we're preventing cancer. What an exciting mission. In a practice, it's important that everyone is aligned. And so we all have to understand what this HPV vaccine is about, because it's unlikely that they're going to see cervical cancer or oropharyngeal cancer in a pediatric practice. So we need to talk about it at an in-service or something. Once they understand it, then the whole office staff can express how important this is by making it part of the routine bundle, for one. And if a parent starts to ask a question, they can be ready with answers. The CDC has a wonderful sheet with quick answers to the common questions. And if you get to the point where a parent says to the nurse, "No, I don't want that vaccine," instead of closing the door, the nurse or MA needs to keep the door open to the conversation by saying something like, "Oh, in our practice, we are so about preventing cancer. I'm sure the doctor's going to want to talk to you more about this." It expresses to the family, we're not going to just end the conversation here. The doctor's going to want to talk to you more about it.
It's not uncommon for parents or the patients to come in and have concerns about HPV vaccine safety. Sometimes the problem, though, is that we jump to thinking that that automatically means that they're totally against vaccine and they're never going to want to get the vaccine. And so we armor up again with all of the data that we want to throw at the parent or the patient about why they have to get this vaccine or why it's important. I don't know that that's the best approach. So for me, I tend to approach it a little bit different. And so most of the time, I'll start, like I always start, asking some questions. So I'll ask them a little bit more about it, and then I'll sort of answer depending on what it is that they're concerned about. And so what you want to do first is validate their concern, appreciate that they're worried and that they're concerned, and then let them know, listen, this is a really, really well-studied vaccine. It's been studied in millions of people all around the world, not even just the United States, and very few safety signals have actually shown up. And a lot of times, that's all they really wanted to know was, do we really think it's safe, and are we comfortable and confident about it? If you can say that with confidence, be really, really assured that that's truly what you believe, that this is a preventative vaccine, that we're preventing you from getting cancer. Often you can allay their concerns and make them feel a lot better and a lot more comfortable.
And then this last one that I have is from around the world. So again, a lot of our patients feel that this just happens in the United States. And I'm like, no, this vaccine is given to children in Canada, in Australia, and many, many other countries in India, around the world. So let's just look at a perspective from someplace around the world.
Hi, my name is Caroline. I'm a registered nurse, just like the one you're about to see for your vaccination. I'm going to tell you how vaccination protects you and why it's important, what vaccines you will receive, and what to expect on vaccination day. Vaccination is a simple and clever way to protect you from serious diseases now and later in your life. It not only helps protect you, but it also protects the community around you by helping to stop the spread of diseases. All vaccines work in the same way. A vaccine is a dead or weakened version of a bacteria or a virus that tricks our bodies into building immunity against that bacteria or virus. Our immune system remembers this and is able to quickly fight the real disease if we come into contact with it in the future. Vaccination is the best way to protect you from many serious diseases. Some vaccines offer lifelong protection. In other cases, booster or extra doses are needed to continue to provide you with protection. You may not have heard of some of the diseases before because they are no longer very common, and this is because we keep vaccinating against them. Today, you'll be receiving a human papillomavirus or HPV vaccine to protect you from a range of cancers and diseases caused by HPV. The best time to get the HPV vaccine is in your teenage years before you are potentially exposed to the infection. HPV is a really common virus that can spread from person to person during sexual activity. It can cause cancers and diseases in both males and females. Many people will have an HPV infection at some point in their lives. In most people, the virus causes no symptoms and goes away by itself. But sometimes it can stay in the body and cause serious illness or cancers of the cervix, vagina, vulva, anus, throat or penis, or genital warts. But there is a way to protect yourself. The HPV vaccine protects against a range of cancers and diseases caused by 9 types of HPV. This vaccine is being provided to students in schools across Australia. 2 injections are given to you 6 months apart. Depending on which state or territory you live in, this is in either Year 7 or Year 8, aged 12 to 13 years.
Yesterday, the teacher told us to wear short sleeves and eat a good breakfast.
Make sure you pack yourself a decent lunch.
When it's time to get your vaccination, you will be taken into an area to see a nurse. There may be other students in the room already with other nurses. The nurse will ask you some questions about you and your health, including your name, date of birth, and address. The nurse will check that your consent form has been signed by your parent or carer. Ask if you're feeling well today and if you have any allergies. The nurse may also have to ask some questions that may seem silly to you, but it's important they know the true answers so that they can make sure you're okay to have your vaccination today.
Yeah, she gave me this stress ball to calm down and relax. Thinking about something else and not about the needle. I just played with a little toy and wiggled my toes just to distract myself a bit. She told me to move my shoulder to make it feel better and go sit down afterwards for 15 minutes and tell her after if I'm not feeling well.
Yeah, just to keep your shoulders down and keep your hand relaxed so keep the muscle nice, soft.
The nurse will then give you the vaccine in your upper arm. Whilst getting your vaccine, you may feel a little pinch, sting, tingle, or even a mozzie bite sensation. It is important to remember that the more relaxed and distracted you are, the less you will feel. You'll then need to wait for 15 minutes after you've had the vaccine to make sure you're feeling well. Well done, you did it.
Sure, right? Felt a little bit of a pinch, but wasn't too bad overall.
In the end, I was fine. Good. It didn't hurt too much. I overthought it because I thought it was going to hurt a lot, but it turned out it was only a little pinch.
Remember, vaccination is safe and it helps protect you and the rest of the community from serious diseases. If you want to find out more about immunisation, visit the website.
So yes, this is, what the Department of Health at Australia has prepared. Again, for me, what has always worked is the way to get started is to quit talking and begin doing. So I know I talked for almost close to an hour now, but at the end of the day, I hope that when you guys go back with that motivation to, start doing something about it, and also reframing this and talking to your families, your patients, in a different way. I did include what, the sort of worldwide timeline for HPV vaccine is. I feel that sometimes if our perspective is bigger, we understand the part that we play in it. So, basically up until 2020 is what has happened so far with this particular infection and the vaccine. And going forward, what they're looking for is, like in 2020, WHO launches the strategy for worldwide cervical cancer elimination. The target is 2030 to meet, the vaccination, screening, and treatment guidelines. And it's also projected near elimination of cervical cancer in low poverty US communities, projected near elimination of cervical cancer in high poverty communities of the United States. And then, again, maybe 40 years down the road, projecting almost 90% reduction in mortality if the WHO initiative goals are met. Sometimes I feel that if we have a timeline or if we have a roadmap, which is more, worldwide, and you're looking at it, at the picture from a different angle, it allows us to understand that those little conversations we have in our clinics with our families, with our patients, it all adds up to this, basically. So yeah, in conclusion, thank you again for this opportunity. If you have any questions, you can email me, or if we have time now, I guess we have 5 minutes. I am happy to take some questions now as well.
There was one question in the chat.
I'm sorry,
Okay.
Go ahead, Lee.
Sorry, Dr. Amy.
Nope, you're good.
How do you approach custodial parents who disagree with each other on vaccinations?
Yes, we have encountered that a number of times actually in our practice. We have encountered that with COVID vaccines as well. A lot of times the approach I personally have used is I will speak to each parent sort of separately, try and find out what their reservations, their questions are. A lot of times I think I always believe that what joins us is way more than what differentiates us, in other words. So yes, there are always areas of differences that I can't sort out, or it's very hard to sort out. But I always try to figure out what is our area where we agree, on some basic points, on some basic fundamental concepts, and then build from that. Have I been successful in every situation? No, I'm not going to be, I'm not going to lie about that. It's impossible. It's life. But the way I approach it is I speak to each parent at their own sort of level, validating, listening to what their concerns might be, offering my suggestion, my solution, giving them the opportunity to talk about it. Sometimes they may decide to come together to an appointment. And then, sort of sit with me and try to hash it out, so to speak. Sometimes they may not be comfortable to even do that. And so it could be like a phone conversation we've tried to have, do a conference call or something like that we have tried to do. And we have been successful in some of those situations. I hope that answered your question.
Great discussion and excellent question. Does anyone else have any questions? You can either unmute yourself or put them in the chat.
And while we're doing that, I'm going to open the poll.
So I want to thank you again, Dr. Verma. That was an excellent talk. It's obviously something that you feel very passionate about, and we appreciate that and agree with that. You know, to me, it's always been kind of a no-brainer. It's our only cancer vaccine.
Precisely.
So, yeah. And I will say, personally, both of my teenage sons are vaccinated.
Oh, good.
Actually, Matt is only 12, and he's already done. So thank you so much for talking with us. And please feel free to join us on any of our Grand Rounds presentations. Lee has made it available to everybody who wants to join us. So we appreciate your participation. And y'all, if you want to send her any questions, you can do that to her email or to me or Lee, and we can forward. And if you want to get your continuing education credits, just go ahead and fill out the poll. But thank you again, and I hope you have a great day.
Thank you.
Just one question. What
Yes.
do you think is preventing the mandation of this vaccine? Why is this not getting mandated like the Tdap and HPV?
Yes, and in fact, even the video from the Australian government, the HPV vaccine is being given in schools over there. So it doesn't even ask the question, is it mandated in schools or not, like parents over here are asking, because what happens is when there is a difference, like Tdap and Menactra, yes, the schools need it, but the HPV, I don't need it as a school system. It begs the question, the parents are always asking why, and they feel that, or they sense a difference. And whenever there is a difference, they sense that there must be something wrong with it, I guess. That's why there is a difference. You never think positive, you mostly think negative. And so, yeah, I mean, I think as a resident, it was the first time that I was asked to present on HPV vaccine. And I was given data from Canada, from India, from Australia, where the voice in which, the language in which we talk about this vaccine, we keep it at par with all the other vaccines. We don't differentiate. I don't know over here what, personally prevents that mandate. Or I feel even before we get to a word called mandate, I think we should just talk about the vaccine at a similar footing with the other vaccines and reframe it and call it a cancer prevention vaccine for both boys and girls. I think that first has to percolate into the general conscious of society, whether it's our media, whether it's social media, whether it's conversations that we have in our hallways, with friends, with family. That reframing has to happen. Again, so when you say a mandate, it becomes like it's compulsory, you have to do it. I feel doing it versus that route, doing it the route where we are reframing, we are talking about in a completely different language, the voice is different, the vocabulary is different. I feel that percolates better. And again, we have to align ourselves, I feel. We speak in many voices, and that's where I feel that the message is getting lost. I mean, again, that's my personal opinion.
Yeah, thank you. No, what I was trying to ask is, like all other vaccines, why is HPV still considered an optional vaccine? Why has this vaccine not yet
That's my question too. No, I mean,
okay.
if I can answer your question with another question, I'm sorry, I don't have an answer to that because, again, that's exactly my question too. I'm like, why is this considered a different optional vaccine? Is it how, I don't want to use the word, but politically motivated this is, or how we see things, or how we differentiate things. I feel that even before we get to that point, because we are obviously not at that point, and your question is my question, I have to first align my vocabulary. I have to speak about it in a different way, because little by little only will the bigger picture change. So there is no one reason that I am aware of myself. If anybody else in the audience is aware of, please chime in, because that is my question too.
Yes, everybody's quiet, but
Yeah.
thank you so much.
Hey, it's Dr. McWhorter. Can you hear me? Can you hear me?
Yes, ma'am.
Okay. I was going to say, it's, of course, a lot of politics around the vaccine, but admittedly, when you look at pertussis and meningitis, you can get that in school sitting next to somebody. You're not going to get HPV sitting next to somebody. But when I bring it up, I mentioned that you've already had a cancer vaccine. You've had hepatitis B when you were a baby. And it's weird, that one is required. But to let people understand that you've already had a cancer vaccine, this is our second cancer vaccine.
Okay.
And I guess, so I understand why it's not required. Not that I don't give it to both my patients anyway. But it's not you could say, public health risk in the classroom, right? So I kind of get that why you don't have to require it, but at the same time, it's a wonderful vaccine. And what I find that helps patients take it is I tell how long it's been out. When you tell them this vaccine's been out over 15 years, and we have lots of data on it, and I gave it to my kids, that goes a long way. I find it encouraging it, and I think the idea is right, not trying to make it stand out, but make it. These are the 3 vaccines you're due for today. And so most of my patients take it because it's the way you present it. But again, I'm going. So I understand why it's not required, and I don't know that I actually personally feel like it needs to be a required vaccine. It just needs to be one that we make routine, just because it's safe and it helps save lives. That's my answer.
You're right, and I did forget that hepatitis B, as you mentioned, and I will also just point out the fact that Dr. McWhorter is my boy's pediatrician, and so that's part of the reason why they're fully vaccinated.
Well, that's kudos to Dr. McWhorter. That's what she mentioned. I've heard that from other parents too, because it's not a public health risk. It is not something which is contagious. It is not airborne. It's not respiratory. So therefore, in a group setting, in a setting where you have people, in close quarters like schools or camps and stuff like that, it's not necessary. It's not compulsory, so to speak. Again, at the same time, there are immunization campaigns that happen in other countries where they do talk about it in a different language, in a different way. They bundle it up, or they will talk about it with same footing. And so, again, it allays the fears, the concerns that the parents may have. Any other questions?
Thank you again so much. We appreciate it.
Thank you.
Thank you. I hope you have a great day.
Thanks.
Yes, I hope you as well. Thank you.